Welcome, everyone. Good to see you. This is our December Implementation Science Initiative seminar. And this month, I am really thrilled to have a good colleague of mine, Dr. Reza Yousefi Nooraie, here. I have known Reza, oh my gosh, maybe, has it been 4 or 5 years now? I think we met at the Implementation Science Conference because we were both
Right.
really interested in work on social network analysis and implementation science. And he was doing some really innovative, amazing work in that area. So we connected then and have been collaborating ever since. Reza is an assistant professor in the Department of Public Health Sciences at the University of Rochester. I think of his work as, again, so innovative in thinking about really advancing some of the social and engagement methods in implementation science and applying work in health equity and mixed methods. He leads the, I don't want to get the name wrong, the equity focused dissemination and implementation function at University of Rochester's CTSA. So we've collaborated together in that. He's also the associate director of the Qualitative and Mixed Methods Research Center at the University of Rochester Medical Center, and really just a really innovative and wonderful collaborative colleague. So I want to welcome him. Just a reminder that we are recording so that we can make this available. So I will hand it over. Thank you.
Hi, everybody. Thanks, Rachel. That was a great introduction. Actually, the 4 or 5 years ago meeting that we had, we were so inspired by your review, if you remember that one. So we were learning from you and your student about the process of review that you did on networks and health. Yeah, so it has been a long time that Rachel and I are collaborating. And specifically, this paper that I'm going to present is one of those collaborations that we worked together last year during the dark time of COVID heat. So let me start here. Today, I'm going to talk about a framework that we developed. We named it PRIDI, Pragmatic, Rapid, and Iterative Dissemination Implementation Cycle. As I said, during 2020, I don't know, it was spring 2020, that everybody was dealing with the rapid changes of COVID and how it revolutionized their life. I have been thinking about how we can incorporate dissemination implementation frameworks and models that we have to understand and to acknowledge these dynamic and fluid environment and fluid landscape around it. So I came up with a very brief and preliminary structure, and then contacted Rachel, contacted Bethany Kwan, and a couple of colleagues in our university, Kevin Fasella and Jim McMahon. And we worked together on a paper. So the framework was revised a few times, and we published it last year in Health Services Policy and Research. Since then, I have been working on the framework, and the one that I'm presenting today is a little bit different from the one that was published. And this is my strong belief that frameworks are living beasts. As soon as you publish them, they change. As soon as people use them, they change because they respond to the environment and people learn about that and people add components into that. So I think that's a natural and healthy process of frameworks changing and adding and revising components into that. That will be one topic for discussion today. I'm really interested to hear your thoughts about how you basically interpret the framework and what components are missing. Okay, so first acknowledgement, again, the great colleagues that we work together in PRIDI paper, Rachel, Kevin Fasella, Bethany Kwan, and James McMahon. And also some of the findings and the processes that I'm going to present today are the results of our efforts at the University of Rochester in a CDC supported project that we call it the Rochester Finger Lake Rural Immunization Initiative. And this is a project supported by CDC to address vaccine hesitancy in the region. And I think that's a perfect example of how things change very fast, intentionally and unintentionally, as the environment changes. Okay, so let me start with an example. I like this example very much. Basically, on the surface, it seems like a failure, but when you talk about it, when you discuss it, it seems like a natural process. So last year, I think it was last year, 2020, early 2020, when everybody was so frustrated with COVID surge, and hospitals didn't have any more free beds to hospitalize patients, and patients were admitted into parking lots, etc. People in New York City have those experienced it in firsthand. There was an important piece of news that the Billie Jean King National Tennis Center will be transformed into a high-tech tertiary center to admit patients with COVID. So, and that was a very ambitious project. It was going to be done in a matter of months or less than a month. So that was a big project, and lots of people flew to New York City as the staff, and lots of high-tech equipments were brought to the center, transformed it into a makeshift hospital. That seems very nice. That seems very interesting. And this slide doesn't seem very nice. So in March 18, there was a call for 350-bed hospital in 7 days. In April 10th, the site was opened. In April 27th, they revised it and said, okay, 350 beds is not possible. Let's go with 100 beds. And in May 13th, the site was closed. The overall price was between $52 million to $100 million, and the number of patients treated was only 79. So this site, with this high expense, this very fast development, and very ambitious structure, only treated 79 patients, and then was closed. And this is a quote. This is a New York Times piece about this hospital. It was published last year, and I think it's a very eye-opening, interesting piece of research about how a systemic intervention can go wrong or can evolve unprecedentedly. There were so many reasons attributed to this rather unsuccessful experience. One, the hospitals who were experiencing the surge were aware of the site. There were a couple of blocks distant from the site, but they didn't know how to refer patients. There was no specific structure in terms of insurance, in terms of reporting, anything. So when the patient was admitted to the first hospital, there were no paperwork and system in place to refer the patient to this makeshift hospital. That's one. Two, hospitals were kind of incentivized for having more patients. There was a relief, there was a specific government incentive for the hospitals to treat COVID patients. And then they had little motivations to let go of their patients, even though the patients were being treated in the hallways and parking lots. Three, there were some experiments missing, some equipment missing. So it was a high-tech system, but patients with COVID needed lots of high-tech ventilation systems and other equipments that were not available there. Four, the curve flattened. So the first surge kind of passed, hospitals kind of shook themselves and became kind of more agile and adaptive to the new situation. So they could handle the cases themselves, more or less. And the projections were exaggerated. So it was basically very positive at the beginning. It was very super ambitious, and then they realized that it's not possible. So that's one example of a systemic effort that started with very high hope and high ambition, but didn't go as planned. As you can see in this list of factors that I mentioned, some of them are because the whole system couldn't accommodate for that. So the hospital itself was working very well, but it was not very well embedded in the broader environment, broader context. Two, natural course of events basically changed, and the dynamics of COVID changed, the hospital system reformations changed, etc., and made this hospital kind of unnecessary. And three, there were lots of paperwork and complexities imposed in the system of referral, in the admission, etc., that made it very difficult for people to send their patients to this hospital. So there is one lesson here, and the lesson is, one, when you have systemic interventions, at the time that you plan it, at the time that you have it on paper, to the time that is being done and being basically fruitful, lots of things will change. Lots of different aspects of the context, environment, population, and interventions will change. We have seen it in fast forwarding COVID. So everything changed in a matter of months. The variants came, vaccine, eligible populations, lots of things changed in a very quick pace. But we more or less see the same thing in any environment. Environments and contexts and systems are not static. On the one hand, they mature and they change through the course of lots of complex events that are happening beyond your intervention. And on the other hand, they respond to your intervention. So your intervention, your implementation changes the environment itself. That's why we developed this framework to accommodate for these moving landscapes or these quick changes that are happening, specifically in the context of a pandemic, but we think that it could be applicable to any implementation context. Rachel told me some people who may attend these meetings need a little bit of introduction, so I added a couple of slides to give you a very quick introduction about what we're talking here. What is dissemination implementation? Dissemination implementation is about bridging the gap between the science and the practice, or addressing the barriers and facilitators and developing strategies to adopt and integrate evidence-based interventions into clinical and community settings. Okay, this is a modified definition from NIH. When you look at this definition, it seems very nice, okay? But in the context of COVID, so many of these things changed. The notion of evidence-based health interventions changed. At the first few months that vaccines came out, they were not evidence-based interventions necessarily. Now they are evidence-based. New variant is coming. Those evidence are being refuted. So we don't know the effect of our vaccines on Omicron, or if the new variant is coming, etc. So evidence itself is a living beast. It changes over time. The interventions that we are going to implement to bridge this gap are also changing. I will give you lots of examples about those interventions that change over time. And then we have community settings. We have the notion of patient outcomes and population health. Our definitions about population health also is changing. Remember, the first few months after COVID, everybody was so concerned about distancing. So social distancing was the name of the game. That was the only intervention that was out there. Masking came a little bit later. People started with medical masking, and then fabric masking or homemade masking was approved a little bit late here. And then vaccines came out. Oh, then there were ventilators and the whole hype around different treatments for COVID. And then vaccines came out, and different types of vaccines with their vaccine veins. And now there are variants coming, boosters, children, and lots of other things that are changing. The target population is changing, the interventions are changing, evidence behind them are changing, the context is changing. So many things are changing, they are not static. So we need probably a little bit of tweaking in this definition and this conceptualization of dissemination implementation. Another Dissemination Implementation Science 101 slide. I built this couple of slides based on CFIR, Consolidated Framework for Implementation Research, which is a very popular implementation framework. So implementation starts from an intervention or the thing that you are going to implement. This intervention could be telemedicine, could be, I don't know, competency training, could be a vaccine, could be masks, etc. Every intervention has a core or the essence and an adaptable periphery. The essence is something that if you change it, the nature of the intervention changes. But the adaptable periphery is more or less, basically could be changed, could be adapted to the context and different populations, target populations, without changing the nature of the intervention. I have a couple of slides about the notion of adaptation, which means that now we have our strategies, we have our intervention, we want to adapt it because we want to match these pieces of puzzle with our target population and their context. But sometimes our adaptation results in change in the nature of the core or the core function of the intervention. So the fundamental nature of the intervention changes. People traditionally consider this as a negative thing. People develop this notion of fidelity, that like an adaptation should be fidelity consistent. The nature of the intervention should remain the same, no matter how much tweaking and how much adaptation or modification you do. But again, I give you examples of adaptations that result in the change in the nature of intervention because our reconsideration of the events show that what are we implementing here? This is not the right thing. Let's implement something else. So this intervention and its adaptable periphery is being implemented in a setting, in a system that is basically a mix of inner setting or the context of the immediate environment that is being adapted to, implemented to, individuals or humans that are inside this inner setting. This could be target population, this could be staff, this could be your implementation actors, And this system is surrounded by an outer setting, which is the overall community, overall social system, political system, and financial aspects. So there are lots of factors affecting the success of implementation. These are all based on CIFAR. I refer you to the details of CIFAR. Your intervention should have a specific characteristics to make it more adaptable and more implementable. The culture and the readiness and the structure characteristics of the inner setting matters. Those individuals matter, their stage of change, their knowledge and belief, and the outer setting matter. So these are all determinants of implementation success that we should consider. Again, CIFAR itself is not explicit that you have to address them or you have to consider them repeatedly. It is basically generally assumed as a one-time thing that you, before implementation, you think about all those factors and you develop strategies to address them. But our argument here is that even that should be assessed repeatedly. This is an iterative process. The culture changes, the stages of change of people changes, those people themselves change, etc. So there are, this is the last component of CIFAR here. And then when you have this system, you want to implement this intervention into it, you have lots of strategies. We call them implementation strategies that may facilitate and may address those determinants, potential barriers and facilitators. And there are people involved in that process as well. Your champions, internal leaders, external agents, and opinion leaders and other staff who are directly involved in the process of implementation. So that's the implementation system and atmosphere in a nutshell, according to CIFAR. Okay, so that's just as a quick introduction for the people who need a little bit of more insight about what's going on here. This slide, again, is the same with some examples related to our interventions, our implementation experience related to COVID. So again, imagine your intervention core is face mask. So the core of the face mask to work is the mask should be properly worn, should have basically required material to let the virus, basically to stop the virus and let it go, etc. And then the adaptable periphery for the mask is the type, the room composition, so indoor versus outdoor masking. If you think about that schools, whether you need mask breaks, etc. So the masking intervention could be adapted to the needs of children according to their age, according to their needs, according to their access to the outdoor or ventilated places, etc., etc. Okay, so that's the intervention and adaptable periphery. The inner setting is definitely class space and ventilation, the culture of the class, number of students in the class, etc. Individuals involved in that process are teachers, parents, their readiness, their attitude toward vaccine. What happens if a student is not wearing the mask properly? What is the behavior and beliefs of the teacher themselves, etc. So again, we have people involved in this process. And this class and school is embedded in the broader context of norms, the population norms. What's the overall beliefs about vaccination or about masking, about COVID itself? What is the political climate around it? What are potential incentives? Is there any regional mandates for it? So these are all surrounding this implementation environment. Your implementation strategies to help this masking intervention stick to this environment and work and integrate to the practice could be training. You may have trusted messengers at the school, I don't know, school principal, other people, seasoned teachers talk about masking and convince other teachers and parents to adopt the intervention. Whether there are incentives, whether there are feedback, whether there are mask stations, masks being provided to these people, etc. And there might be people who are facilitating this process. Again, staff, local regional leaders, healthcare providers, influencers, etc. So this is basically like a snapshot of this implementation process in the context of masking for school. And again, as you can see here, I have a 10-year-old son. So we all have this experience of how these things evolved, how these things changed. So the masking, whether social distancing at school, arrangement of the desks, etc., whether there are ventilation equipment in the school, the size of the classes, etc. All those changed over time. Okay, so we talked a little bit about adaptation. When we say there is this fluidity and there is this dynamicity in the environment and context, the first thing that comes to mind is, okay, so we need to adapt. There is no one size fit all. We have to be responsive. We have to change things in response to the changing environment. And that's why we have the concept of adaptation that has been in the implementation science for a long time. This definition of adaptation is by Sturman and her colleagues in a few papers that they wrote. A process of thoughtful, deliberate alteration to the design or delivery of an intervention, the goal of improving its fit or effectiveness in a given context. That seems very nice, the definition. Again, I have some comments about, again, given context, effectiveness, all those definitions are also changing. A few papers try to categorize different types of adaptation. So when we read literature of adaptation, we see proactive versus reactive adaptation. Proactive means that it is a little bit more planned. At the beginning of the process, you think ahead about what should be adapted. So you develop a team, etc., to think about adaptations that might happen later. Or reactive adaptation is being forced by the environment. You didn't plan for it, you didn't expect it, but you have to do it. And that's reactive and sometimes unplanned. And I mentioned the notion of fidelity consistent versus inconsistent adaptation. Fidelity consistent adaptation preserves the nature of the core, but inconsistent adaptation changes the core. And we have systematic versus unsystematic adaptation. Systematic has a process involved in the adaptation. You may develop a stakeholder team, you may develop specific plans or adaptation framework you use. Unsystematic is just, oh, let's do it. We have little time, let's do something. Again, people have judgments around those things. Proactive is definitely better than reactive. Planned is better than unplanned. Fidelity consistent sometimes is better than inconsistent, and systematic better than unsystematic. But again, I'm always thinking COVID here. Sometimes we are forced to do things. There is nothing that we can do. Nobody expected things that happen this way. And we have to be responsive, and we have to be even reactive, but systematic reactive. You might be familiar with this framework. This is Frame Model by Sturman, Bauman, and Miller, published in 2019. This is a very useful framework to structure the process of adaptation. I don't go into the details of this framework. It has lots of moving parts, but they try to basically categorize different aspects of adaptation. For example, the reasons for adaptations, who is involved in the decision to modify, what was the goal of adaptation, and when it happened, again, pre-implementation, is it basically proactive or reactive, etc., whether it was planned or no, and what is modified. So what are different aspects of adaptation here? What is the nature of content modification, etc. This is a very nice list and helps structuring the process of adaptation. But again, my feeling when reading these papers or these frameworks is that the nature of implementation generally stays the same. So you adapt, you make some tweaks, you make some modifications for example, tailoring, adding elements, or substituting something with something else, or loosening structure, and you have some reasons for that. So you want to increase reach and engagement, increase retention, improve the feasibility, reduce costs, etc. But the big picture remains the same. And when the big picture changes, we call it fidelity and consistent adaptation. It kind of changes the nature of the whole thing. It's not adapting things, creating new things. And again, our experience in the project that I'm going to explain, and many other people's experience in the context of COVID, was that it happens a lot. It happens a lot that you change things drastically and radically. Okay. Kirk and colleagues in 2020 worked on Frame Model that I showed you in the last slide, and developed Maddie. Maddie is model for adaptation, design, and impact. It puts adaptation in context. It is a very nice effort to develop a causal pathway or causal structure for adaptation. So what happens that we adapt, and what happens when we adapt. And they basically structure different types of adaptation as systematic proactive versus systematic reactive, unsystematic proactive, and unsystematic reactive. I think this is the worst thing. You have time, you are proactive, but you don't have a method to do things. But many times it happens that you are systematic and proactive, and many more times it happens that you are systematic and reactive. And I think this is the nature of PRIDI, to be more systematic around both proactive and reactive changes that may happen, both fidelity, consistent, and inconsistent changes that may happen through the course of implementation. So it makes the process more systematic. This is Maddie. Maddie has three main basically domains and components here. One, adaptation characteristics. This is based on frames. So what is being changed, the nature of the change, who is involved, for whom, and when. 2 possible mediating, moderating factors that happens in the adaptation. So adaptation in context, whether the team is formed, who are in the team, whether there is a support for that, whether there is a systematic process, etc., and the outcomes that may happen. Still, like, this is a very nice effort, and in my knowledge, that's the first effort to develop a causal pathway for adaptation. But again, we think that there is a broader context. There's a broader constellation of factors and systems around adaptation that we have to consider, and we have to see, and we have to be ready for. And that's the nature of PRIDI. Okay, so let's start with this when I'm explaining PRIDI. This is a little bit more Canadian here. This is knowledge to action framework based on Canadian Institute for Health Research. And I like it so much because it is by nature iterative. This is the process of implementation that they developed like more than a decade ago, and it still stands. It shows the process of implementation as a cycle. Implementation as a cycle, implementation as an iterative process is being advocated more recently. Years ago, when there was no talk about implementation science, people in the context of quality improvement have been talking about iterative quality improvement, the cycles of quality improvement, PDQA, and other types of cycle. But now people are recognizing more and more that the whole process of implementation is by nature iterative, by nature repetitive. And we build the PRIDI framework based on this cyclic nature of implementation. Okay, so what we are going to explain in PRIDI is putting this process of implementation in the context of this broader machinery of factors that affect implementation. And those broader machinery of factors are called implementation landscape. And there are different aspects and dimensions that we try to develop or try to explain in the implementation landscapes. So this is the paper. This is the original paper that we published in 2020. The link is there in the slides. I guess the slide will be shared with you. This is the PRIDI that we shared in the paper. It starts with the cycle that I showed you. This is knowledge to action framework. You start, you plan, and then you adapt, you act, you evaluate, you report. This is the DNI cycle. And we developed 4 factors around it. We call them implementation landscapes. And we thought that it is much more appropriate to the context of COVID because everything is fast forward. And I will give you examples related to that. For example, the nature of intervention and implementation strategies, its core and its periphery may change. So even within your cycle that you tweak everything, what you are going to implement may change itself. So then you start with implementing intervention X, but you may end up with implementing intervention Y because X doesn't show to be working. It is very well connected to the notion of evolving evidence. So evidence-based and science around the intervention and implementation itself may change. Through the course of implementation, you collect some data, sometimes systematically, sometimes unsystematically, about the effectiveness of the intervention, but the surrounding environment also is changing. Again, think vaccine here, that how evidence-based behind vaccine is changing. Your goals of implementation might change, and hence your evaluation frameworks, the outcomes of implementation may change. You may have a goal in mind and then end up having a different goal. And individuals and contexts around them may change. So these 4 moving parts affect this internal cycle of implementation. We call this a double loop learning. Some of you who are familiar with organizational science or system science might have heard about double loop learning. I will explain a little bit more. First explaining single loop learning. Single loop learning starts with a mental model or your worldview, your goals, and then you have a specific rules. You start a cycle. It is cyclical. You make decisions, you test them in real world, you get feedback, and you revise your decision. Okay, this is a single loop learning. A loop is happening. This is iterative process of implementation. You can put this knowledge to action framework here. A double loop learning has another cycle here. Your mental model is also changing. As you implement or as you test things, you know yourself better. Your worldviews values, your assumptions, your big hypotheses about the whole thing may change. So there are two loops happening here. One, the original loop of you plan, do, study, act, and the other loop is about changing your mental models and hypotheses. So double loop learning is more agile. Double loop learning is more flexible and more responsive to the changing environment. And there's even a triple loop learning. So the triple loop learning, you know the single loop, you know the double loop. The triple loop, or the other surrounding loop, is about basically changing your processes itself. So not only your assumptions changes, not only your beliefs changes, but also the processes that you test them and apply them changes. In this basically presentation of triple loop learning, I found the explanations very nice. So the single loop is, are we doing things right? Are we implementing intervention X correctly? Okay, so that's a single loop. We may learn through the course of implementation. The second loop or double loop here is, are we doing the right thing? So are we implementing the right intervention here? So this is a bigger question. It's a more fundamental question. And the third loop around is, how do we decide what is right? So the notion of rightness, the notion of what works or what is basically what is right and what is wrong changes. Again, that's one presentation of the triple loop learning. You get the concept that when you go basically outside in these loops, from the single loop to the double loop and triple loop, your questions become more fundamental, become more existential. And you need more fundamental changes in whole processes. It's not just tweaking a little bit of strategies or adding or basically removing some component. It's about changing the whole big picture. This is the newer version of PRIDI. That's our effort based on our newer experience of vaccine hesitancy that I will explain. Again, the center of this circle, this concentric circle, is the iterative implementation planning. You can put basically this knowledge to action cycle in the middle of it. And then it is surrounded by three main aspects of moving landscape. Your goals and outcomes changes, your actors and targets change, and your intervention and strategies change. These three factors, again, sometimes are beyond your control, but you have some agency and you have some decisions to make. So you decide your goals and outcomes, you decide your actors and targets, and you decide your intervention and strategies. You have some control over them. But even the third loop around it, the surrounding circle, is much beyond your control. So individuals and context and the whole population change. When we talk about vaccination of children, you don't have much control about, no, I don't want to do children. So this is the thing, that's the reality of it. Now we should think about children's vaccination. So the individual and the context of the environment changes. The evidence base is the science, is the evolving science behind it. You may see published papers, you may see population-based data that are coming out about the effect of interventions. Again, you don't have you have little control over it. And then your resources and capabilities change. So again, you have little control over your resources. You can adjust it or readapt it in so many different ways. The essence of PRIDI is these multiple loops. You have these original implementation cycles that are being affected by outside loops. And for some of them, you have more control. For some of them, you have less control. Okay, so let me give you an example here about PRIDI. I mentioned the study that we are still doing. It's Finger Lakes Rural Immunization Initiative. It's a project supported by CDC. It's basically a supplemental support for existing CDC projects, and it had a very small turnaround time when they announced that we have this extra funding to support projects. So we put together a proposal in a matter of a couple of weeks. So when we did that in March 2021, we had little idea about what's going on in the population, how our intervention will unfold, and how we are going to implement it. What we suggested in the proposal was we are going to focus on the notion of trusted messengers. Trusted messengers are the people who may affect, may influence other people's decisions and beliefs regarding being vaccinated. These trusted messengers could be some people who are already vaccinated. They could be trusted messengers for their family and friends. Healthcare providers, as an inherent trusted messenger, people listen to their doctors, listen to their nurse, etc. And community opinion leaders. There are people who are more recognized, the pastor in the church, or other people who are being recognized and being known in the communities and can influence people's decisions. And then we thought that we will develop a 4-component intervention to engage trusted messengers in influencing their social networks. One, increasing their capabilities by educational packages that they can share with hesitants about nature of vaccine, nature of COVID, etc. Addressing their confidence, trust building, and motivation strategies. We train them about communication, we train them about being motivational, etc. We facilitate the whole process of vaccination. So convenience, addressing convenience, for example, by providing satellite sites for vaccination, providing vaccine to the rural areas. And contagion is basically basing this intervention upon social networks. We motivate trusted messengers to talk to their social networks, both clients and patients, and also friends and family, etc. And we motivate them and remind them about these communications. That was our original idea. And we had 3 populations in mind. So it was a 3-round project. First, we focused on hesitant groups in rural areas in New York, in Western New York, Finger Lakes region. And then we go to the next population. It could be Latinx communities. It could be seasonal workers in the farms, etc. And the third community could be Mennonites. So again, we had some populations in mind that could be our targets for our population, priority populations to work on. That was written in a proposal in March 2021. This is like a few months past, a couple of months past. In July 2021, we sat together in a retreat and said, okay, so we had the funding. Now we tried for a couple of months. Let's revise these processes. Let's see what we have. Let's see what's going on. Our program goal was, this is a logic model for our program that we developed through this retreat, one-day retreat that we had. The problem, yes, low vaccination rates. At that time, we reached a plateau of 60%, something. It didn't go up in our rural regions, again, more or less in different counties. Increased vaccination rate for eligible population to more than 60% was our goal at that time. We reached that number in some counties since then. Our objective was to increase access and also increase demand. Let's see, our activities, we define them as 1, present program goals at hospitals and practice staff meetings, because we want to reach out to these people. We want to find trusted messengers, and then recruit vaccine champions and trusted messengers, and implement trusted messenger interventions, develop supportive learning environments, etc. And our output or evaluation frameworks was, we want to see basically the commitment from people, successful implementation of vaccine workflows in beta sites, modification of intervention. We were so optimistic now I'm looking at it. And then replication of in-practice workflows at other sites. So we have some beta sites, and then basically scaling it up, etc. And vaccine administration. And ultimately, we will see that the number of vaccinations will be increasing in our region based on our regional data. So that was the general idea. We didn't change that much things. A few things we modified was, at the proposal, we said, okay, people who are vaccinated could be our trusted messengers. We can reach out to them and ask them to invite other family members and others to be a part of this program. In July, we decided it doesn't work because we have little access to these people. People who go being vaccinated in rural areas, we have little touch points to contact these people after vaccination. We developed some online surveys for them to use, QR codes that they scan. Many people didn't do this stuff. So our online survey after vaccination didn't work much. We realized that we don't have much of leverage and much of communication channels with people who are newly vaccinated. And then they said, so let's work on healthcare workers, because they are by nature trusted messengers and we have better connections and better networks with them. Let's work on that. We also had thought about fire department, EMS organizations, first responders as potential trusted messengers. We thought, okay, these are good ideas, but they may not work for us because we don't have the connections. So we made some tweaks in the processes in July when we reconsidered the process. And I developed this timeline of events that happened during the course of our project so far. I want to just give you a quick overview, and then I will get back to some of them in the following slides. So in April that we started this project, there were some relaxation, some business openings happening. In May, we had some regional peaks in our region. In July, Delta variant came and people were scared, and some rises in the stats, and Omicron is coming in November and December. What else happened? There was some basically unsettling news about J&J. J&J was paused, Johnson & Johnson was paused and then resumed for different reasons. So we had some hesitancy happening because of J&J. We thought we have to address that. We have to work on that. People had lots of concerns about this is not a CDC or FDA approved intervention. Pfizer was approved fully by FDA in August. So we had some changes happening here. The nature of our intervention changed. Children became eligible in the fall, and boosters started to work in the fall. So we had new populations coming into our circles. Our vaccination rates reached plateau in July. It increased a little bit during summer and in falls. And then in September, something very important happened. New York State, in August, September, New York State mandated vaccination for every healthcare institution, and then followed by every institution more than 100% staff. That was a big change because on the one hand, it kind of removed some of the concerns that we have that I will explain in a moment. And on the other hand, it resulted in some staff shortages. Some staff said, I don't want to be vaccinated. So they left the healthcare institution. So it increased the workload of existing staff and reduced their bandwidth to participate in the interventions that we had in mind. And then our leading organization, the Finger Lakes Vaccine Hub, basically kind of diffused and restructured a little bit. So we changed our leverage points into the system. So this is a snapshot of what happened through the course of these few months. And as you can see, every single of them could change the whole nature of our intervention. New variant, new populations, because new population result in new trusted messenger group. So the person who is trusted messenger for parents of children is different from the trusted messenger for older population, etc., who go to the doctor sometimes. And also the notion of evidence behind vaccines and also the resources and capacities that they have. Okay, so let's map all these factors on PRIDI. So this is our process of implementation cycle, the way that is being now, with no radical changes. So this is the single loop. Okay, within the single loop, we started with, okay, we have to identify trusted messengers, we have to target them, we have to engage them in intervention, we have to assess the rates, etc. We evaluated the process. We found that trusted messengers are difficult to find because they don't respond to our online survey. Many of them who are healthcare providers are already overburdened. They don't want to engage in these kind of communication and conversations. We started with community trusted messengers, and then we modified our strategies to let's think about self-identified trusted messenger. I don't want the celebrity. I'm looking for whoever thinks that they can be trusted, they can affect their patients and social networks' beliefs about vaccine. Our data sources changed. As I mentioned, we thought about surveying the people who have been vaccinated, inviting them to engage their networks in the vaccine communication. We realized that those surveys don't work because people in rural areas are less likely to participate in those online surveys, etc. And then we changed our process into more active reach out. We go to clinics, we reach out to clinic leaderships rather than online surveys in a passive way. Now we have lunch meetings at local clinics. We go present for them. We basically have a face-to-face conversation with them. And then we added our qualitative evaluation to our quantitative evaluation that we had in mind. So that's basically the very natural single loop evolution of our processes. But things happen that are more radical than that. Okay, so this is the second loop. We should talk about goals and outcomes, intervention strategies, and actors and targets. I have examples for a few of them, and I like this, how the way these slides move. So interventions changed. We started with an idea of mostly text messaging intervention or online intervention to address these C's: capability, confidence, contagion, and convenience. And then we realized that our intervention needs to be more face-to-face rather than online. We have to go there and talk to people because they don't engage in these passive processes. So we changed our intervention into more face-to-face and more communicational. And then we realized that different people have different needs. Different trusted messenger at different regions have different needs. We have to talk to them first about what they need and what they want us to support them, rather than imposing our intervention on them. And then nowadays, currently, we changed our process into going to the clinics and talking to people. And for some reason, by chance, we had a group of people who were experts in theater-based performances. We created these performances about best ways of communication with patients about vaccines. So good ways and bad ways of communication. We developed a theory-based intervention to do that. So our lunch meetings with these staff are basically a little bit of introduction about what we're doing, providing some resources to them, and then a little theater that they can watch and they can engage in. So the nature of our intervention, as you can see, changed a lot from these text messaging online intervention that we had in mind. What else? The goals and outcomes changed. At the beginning, our outcomes or evaluation frameworks were based on, we want to do some qualitative interviews with target population, we get our regional data and online surveys. We realized that online surveys don't work, we removed that. Vaccine exit surveys don't work, we remove that. Now we have post-meeting survey. In those launch meetings, we send them the link to a survey immediately after the meeting, so they participate in that. We changed something about our evaluation frameworks. Our actors and targets changed. We started with recognized trusted messengers. We said we want to find people who are influential in the community. These people could be healthcare providers, community leaders, and people who are being vaccinated. We discarded the idea of being vaccinated easily. We changed the process from recognized trusted messenger into self-identified trusted messenger. And now we are basically saying everybody is a trusted messenger. Every healthcare provider is a trusted messenger. We don't want to be exclusive. We have little leverage. We have little access points. We want to engage everybody who is interested in this. So healthcare providers as trusted messengers are mantra. We don't basically distinguish between different types. And now we are thinking about adding other trusted messengers into the loop because our theaters are working very well and everybody could be engaged in the theater and performance about the communication, a bad communication, and good communication, and it could be applied to community-based and other types of trusted messengers. So the actors and targets also change. Let's go to the outer circle here, which is basically our resources and capabilities, individuals and context, and evidence base. So individuals changed. We started with the idea we want to go with the rural unvaccinated. It remained the same all over the course of our study. We wanted to move on from these rural unvaccinated to seasonal workers, African American Latinx communities, and Mennonite communities. We realized over time that this first group is big enough and our interventions need lots of tweaking, lots of time to work. So we are still focusing on that. We are not graduating from that group yet. So rural unvaccinated stayed the same. During middle of summer, we had this notion of unvaccinated healthcare providers because healthcare providers are trusted messengers, but at the same time, many of them are not vaccinated at that time. We thought that. Then mandate happened and kind of solved the problem. So whoever remained is mostly vaccinated now. Now we are thinking about children being added to our individuals and context of our intervention. Again, this context may involve surges, may involve peaks of the infection. If we see that, because like the stats are rising in our region, if we realize that during holidays we will have lots of more patients with new variants of COVID, then it means that we even have less access point to the trusted messengers. We need to focus on different populations. And the evidence base, as you know, changed. The effectiveness of vaccines, long-term effect of vaccines, evidence for boosters and children, evidence for our intervention. So healthcare providers as trusted messengers, do they work? Do they affect patients' decision-making? We have some evidence from flu vaccine. We have some evidence from other vaccines for children. We have little evidence about the effectiveness of trusted messengers for COVID-19. Effectiveness on variants now, we are dealing with our theater-based intervention. We have little to know, and basically have little evidence behind theory-based interventions to improve vaccine communication, whether those performances work. And as more evidence comes out, we may change our strategy. And the last one is resources and capacities. So we started with this understanding the workload will be high for healthcare providers. And after mandate and staff shortages that happened, it became even worse. We had support from local leadership. That was nice. So we still have that local leadership support. We use our local connections to reach out to clinics, to set up appointments with them, to go to their clinic and talk to staff. And we had this expertise in the team for performance-based interventions. We didn't plan for that in the proposal. Now we think it works nicely, and people have good feedback and good learning based on that. And we had people who are experts in self-determination theory and behavioral theory that may inform the intervention that we are implementing. So these are all the things that we didn't plan for, but now we are building our interventions upon them. Okay, so as you can see, PRIDI is trying, so we are trying in the context of this study to put our efforts into this bigger context, the moving landscapes that may involve our resources, the evidence, the interventions, the actors, the people, and the context that they are in, and our goals to respond to those changes. We think that PRIDI is a nice framework to put implementation in the context of learning healthcare systems. Learning systems are, according to HRQ, are the systems that are learning, basically based on internal data and external data from the target populations and community. And they respond to the emerging needs and develop interventions to address those needs. And we think that we need that connection point between our implementation processes and those broader contexts. I skipped this slide. The last slide. Our original goal for PRIDI was two things. One, to organize and inform the process of evaluation. We developed a template for people to use when they do this iterative process of implementation, planning, and evaluation. We still think that that is helpful, even with changing content of PRIDI. Understanding those broader contexts and their fluidity and dynamicity is important through these processes. And the other important objective that we had is to understand better this complexity, the causal pathways around it, and how these factors affect our decisions that we make through the course of implementation. And that's why PRIDI is evolving. And I think it's very natural that it evolves even more as we learn more about this dynamic context. And I invite you to help evolving it and basically reflect on its component and what should be changed more. So this is my last slide. I will be happy to answer questions. I guess I'm over time a bit.
Amazing. Thank you so much. This was really, really, really fascinating. You completely blew my mind with the notion of adaptation in terms of just the examples with COVID, just illustrated that in a way that I think I have not seen it before. So that was really, really, really interesting. And I hope you all publish that in terms of the nature of those changes that you documented. Because I do feel like COVID is so real for people that it just hits home in a different way that I think everyone can relate to in a different way.
Exactly. So again, I don't say COVID is an opportunity. COVID is a very sad thing that is happening, but it shows us how things change very fast and how should we be agile for the next pandemic that may happen or next disaster that may happen. Again, during the first few months of implementation, during the first few months of COVID, there were papers, and I'm sure you read some of them, that they said implementation is not necessarily implementation science is not a priority right now. We have to do it fast, and we don't have luxury of waiting and planning and those stuff that we do in implementation. But I don't agree with that. Implementation science could be more agile, could be faster, could be more reflective.
Absolutely. And I think some of your notions about the fundamental questions about what counts as evidence and when is something implementable, it kind of turns all that on its head. So I want to open it up to any questions. We have a few minutes. Anyone have questions, comments, anything they want to ask about?
I have a question. So I was wondering, the 3 learning models, when you implemented or when you wrote the proposal for CDC, what kind of, were you looking at the 3 loop learning model, or what was your framework for that?
So no, we didn't have these 3 learning models. So we added PRIDI to learn about what is happening. So PRIDI is not a part of the proposal we wrote for CDC. Proposal for CDC was written in a very, very straightforward way. We need to find trusted messengers. We need to train them and help them communicate with people about vaccination. That's it. So, and CDC was okay. This is not research. This is supplemental support for doing things in the regions, and there are, I guess, like 70, 80 other sites across the country that are doing similar things. Some of these sites are focusing on different communities. Some of them are focusing on different interventions. We are focusing on trusted messengers. So it was written in like a very straightforward proposal. It was not written in an iterative way.
Thank you.
So PRIDI is basically our lens to understand why we are changing things. Because again, the luxury of CDC project is that it's not research. So the funding is there to make changes in the community. And we have this luxury of changing the goals and changing the processes, because we learn that some things work, some things don't work. It happens less in the research that you have a very set goals and outcomes and aims. But that, I think this reflects the reality of implementation practices more than implementation research or implementation, basically investigations. So what happens in a healthcare system is more or less like this. I remember during summer, everybody wanted to transform to telemedicine, because telemedicine is the only way that works. People cannot go to the hospital. And there were infrastructures in some places and there were not in other places, and people quickly did things, and nobody evaluated, at least in our institution, nobody evaluated in a systematic way that what are the determinants of success, how it may work, and in what context patients and healthcare providers have better experiences. But it happened very fast because that was the need.
That's a good point, that often we don't have the luxury to be adaptable like that, except in those service projects, right? In the context of the implementation science studies, it can be tough to say, okay, we're going to change this.
Yes. Exactly.
Yeah. But I love those lessons too around the trusted messenger and how you all frame that. It's really rich. I realize we are at time. Really, really phenomenal. And I look forward to the next version of what comes out from this in terms of adapting the model.
This is work in progress, and we are still learning. And again, Rachel, every time that I write these kind of things, you come to my mind. Okay, so let's reach out to Rachel and work on the next step. So you may hear from us very shortly. But yeah, thank you for the opportunity. Thank you for listening to this, and I'm happy that you like it.
Great. Thank you. And there's some notes in the chat. So we will send these out. Thank you again. And thanks everyone. Have a great week. And hopefully we'll see some of you at the D&I conference in a couple weeks.